Hello, my name is John Kovalt from the Alcohol Research Center, Department of Psychiatry, UConn Health, and I'm going to talk today about pharmacotherapy of alcohol use disorders. That's an area that we've done several clinical trials at our own center for some of the medications we'll talk about today. First, I'd like to comment that alcohol use is common. About 2/3 of Americans drink alcohol on a somewhat regular basis. But only 10% of people consume the majority, 70% of all alcohol in the U.S. And about 8% of Americans have an alcohol use disorder. Heavy alcohol use or binge drinking, that's more than 4 drinks for a woman, 4 or more, or 5 or more for a man, is associated with significant health effects. Alcohol has direct effects on GABA receptors, those are inhibitory neurotransmitter receptors, and on excitatory NMDA receptors, as well as indirect effects on limbic dopamine reward systems, and also on the amygdala fear center, part of the anti-reward system. Chronic effects of heavy alcohol use are thought to set the hedonic set points and is part of the pathway from controlled to compulsive use of alcohol. Currently approved medications that I'll speak about for alcoholism act by several different pharmacologic mechanisms. So in this illustration, the type of neurotransmitter system that's affected by alcohol at different concentrations as you move from the effect of 1 drink at 10 to 15 millimolar or breath alcohol concentration, where dopamine, a rewarding neurotransmitter, is released, to higher doses at moderate intoxication, for example, a breath alcohol of 100, where you start to inhibit NMDA receptors and enhance GABA signaling. And in a person who is not accustomed to heavy doses of alcohol, at a dose of 200 or 300 breath alcohol concentration, they can exhibit super or coma, as in several profile cases of fraternity hazing. What's indicated as binge drinking is kind of the blood level of alcohol that's achieved in women after 4 drinks or men after 5 drinks. So I just want to spend a moment about the progression of addiction. We sometimes conceptualize it as involving several steps, initially being impulsive use and enjoyable use, and moving on to a compulsivity use. Here are 3 stages of the addiction cycle. Preoccupation and anticipation with use of the substance, such as alcohol, which seems to be related to dopamine release, and one of our medications targets that. Then with the actual use of alcohol, a person becomes intoxicated due to the effects of alcohol on the GABA and glutamate systems, and different medication, acamprosate, targets those neurotransmitter systems. And then in the withdrawal state, and after long time use, there's a negative affect state that's aversive effects related to chronic use. That's due to adaptations of the nervous system to the chronic effects on GABA and glutamate. So impulsivity dominates the early stages, while compulsive use dominates the terminal stages. And with this transition from early stage of impulsive, enjoyable use to now compulsive is a shift from positive reinforcement to negative reinforcement in driving the drinking behavior. So alcohol withdrawal occurs following chronic alcohol use. Physical tolerance may develop due to neural adaptations to this enhancement of GABA signaling by alcohol and inhibition of glutamate signaling. And this imbalance of excitation and inhibition leads to potentially serious withdrawal symptoms. These include tremor, nausea, fast heart rate, high blood pressure that are related to activation of the sympathetic nervous system. Additionally, people are at risk of a seizure. That's due to an imbalance of glutamate and GABA signaling. And finally, the delirium, a confusion that happens for about 10% of hospitalized alcoholics. And untreated may have a mortality as high as 10% and 25% in those with medical illness, such as being hospitalized for pneumonia or after a stroke. And oftentimes the caregivers are not aware of the alcohol dependence history. So we have medical treatment for alcohol withdrawal that standardly includes giving adequate dose of a benzodiazepine, which are agonists for the GABA receptor, such as lorazepam or diazepam, to produce mild sedation. It's kind of replacing the acute effects of alcohol and then reducing that medication safely over 3 to 4 days. There are other possible medical consequences of alcohol withdrawal, including a chronic brain disorder, Wernicke encephalopathy, that thiamine and folate are important to give to prevent. So these are the currently FDA-approved medications for the treatment of alcohol dependence, and they're intended to reduce the likelihood of relapse for someone who's been detoxified or from return to heavy drinking. The first medication, disulfiram, was approved in 1949, and it interferes with the breakdown of intermediate metabolite of alcohol, acetaldehyde. It's here I noted as a noxious metabolite because it has unpleasant effects. So alcohol is metabolized by an enzyme, alcohol dehydrogenase, to acetaldehyde, and then a second enzyme, acetaldehyde dehydrogenase, metabolizes it to acetate, which is removed in the urine. So this medication, disulfiram, inhibits the second enzyme, causing a buildup of acetaldehyde, which has unpleasant effects. And so disulfiram is basically an alcohol sensitizing medication that produces an unpleasant reaction when a person uses alcohol while taking this medication. So it's used to deter alcoholics from drinking due to the fear of an unpleasant reaction. The second medication approved in 1994 for alcohol use is naltrexone. Naltrexone is an antagonist of opiate receptors, and it interferes with the endogenous opioid-like compounds that bind to these receptors as part of the reward signaling pathway. For alcohol, it appears to reduce dopamine release associated with the anticipation of drinking as well as the actual use of alcohol. There's an oral form that's once a day and then a monthly injection that are available. Some common side effects are nausea and headache, but generally it's well tolerated. Naltrexone is also approved for the treatment of opiate dependence, as it blocks the effect of exogenous opiates like heroin or opioid pain pills. There have been several studies demonstrating the efficacy of naltrexone. In this meta-analysis of 14 studies involving over 2,000 patients, there is a clear effect of naltrexone on the risk of relapse to heavy drinking, with about a 40% reduction in risk compared to placebo. In contrast, there is a borderline effect of naltrexone on the ability to maintain abstinence. The effect size for preventing relapse to heavy drinking was small to medium, and the number needed to treat is approximately 7 in order to prevent one person's relapse to heavy drinking compared with placebo. So the third FDA-approved medication, acamprosate, has effects on the NMDA glutamate and the GABA receptor systems. And so this is acting by a second mechanism, not the reward pathway, but the effects of alcohol that are associated with intoxication. So as I mentioned before, the normal balance between glutamate and GABA system is altered by chronic drinking, and the basis for acamprosate's development was to have a medication that would moderate that imbalance. So unlike naltrexone, which is once-a-day medication, acamprosate is recommended to be given 3 times a day, 2 330 milligram capsules 3 times a day. It's also well tolerated. Some patients initially complain of diarrhea, but it has no hepatic risk. It was originally developed and approved in Europe, where in a meta-analysis of over 3,000 patients, there was a significant improvement in abstinence rates following detoxification. It was initially studied in Europe as a aftercare medication for people who had been medically detoxified from alcohol. But it didn't have much benefit for reducing heavy drinking should a person relapse. In the United States studies, there was limited benefit. One large study showed no benefit, and the main difference is perhaps due to the fact that in the U.S., patients weren't started following detox, but coming from outpatient ambulatory population. I also wanted to mention that in addition to these FDA-approved medications, there are several medications that have been studied that are approved for other conditions, but have been studied for potential benefit in alcoholism. SSRIs have relatively little benefit. There's more support for the following four compounds: ondansetron, baclofen, topiramate, and gabapentin. The last two compounds are anti-seizure medications, and I'll say a few words about topiramate, which has the best evidence and effect size of this group. So topiramate, like acamprosate, modulates glutamate receptors and GABA signaling, but through different mechanisms than acamprosate. Topiramate is FDA approved for seizure disorder, 200 milligrams twice a day, and is widely used for preventing migraine headaches at 50 milligrams twice a day. In studies for alcohol use disorder, a dose in between these, between 200 and 300 milligrams a day, is shown to help reduce heavy drinking. There are a number of potential side effects: tingling of the skin, change in taste, fatigue, some reversible short-term memory problems, decreased sweating, which for some make it not their first choice of medication. So here there are three well-documented studies, one a 17-site, multi-site study, and in all three there was a medium effect size for topiramate in reducing heavy drinking, with a Cohen's d of 0.5 compared to 0.2 for naltrexone. And the number needed to treat using topiramate is only 3.4 to prevent one relapse to heavy drinking, compared with naltrexone's 7. Finally, I'd like to introduce the combined study, a randomized controlled trial that compared 9 different treatment groups. This was at 11 academic sites where they randomized over 1,300 patients, and was reported in 10 years ago in 2006. So patients, the point of the study was to ask whether a combination of behavioral intervention by a specialist in addictions with or without medication had better outcomes. And the two medications that were studied were naltrexone and acamprosate, the two FDA-approved most commonly used medications at the time. All patients who had a medication or a placebo were also given medical management, which consisted of encouraging medication use and encouraging abstinence from alcohol. And so in contrast, the other group on the right-hand side of the slide had medical management about pill use, plus specialized behavioral counseling for reducing alcohol use. And so with each of those two major arms, patients either had placebo capsule, naltrexone, acamprosate, or the combination of naltrexone and acamprosate to test not only whether the combined medications gave a graded benefit, or whether any of these medications combined with behavioral counseling had a better outcome. And finally, they had a 9th group, which was counseling alone with no pills to remove a medication placebo effect. The basic results are listed here under conclusions: that patients receiving medical management with naltrexone, or medical management and placebo pill plus behavioral counseling, or both, fared better on drinking outcomes than any of the other conditions. And in the figure, it shows the odds ratio of a good composite outcome at the end of the 16 weeks, comparing placebo and no behavioral intervention with behavioral intervention alone. The next indicator, or naltrexone plus behavioral intervention, or naltrexone without behavioral intervention, which actually had a slightly statistically better outcome. And as noted at the bottom of the slide, in contrast, acamprosate showed no evidence of efficacy in this large trial, either combined with or without behavioral counseling, or combined with naltrexone. It gave no added benefit. And finally, that the presence of placebo pills in medical management had some positive effect above that of counseling alone. The important outcome here is that things like naltrexone can have benefit for patients in reducing relapse to alcohol when given in a medical setting without specialized alcohol behavioral counseling, allowing access to a greater number of people through their primary care doctor. So in summary, research has provided several effective pharmacologic interventions, both for preventing alcohol use and relapse, as well as for treatment of withdrawal. Evidence for the use of disulfiram is equivocal, and it entirely depends on the patient using the medication. So the placebo, when actually taken, is equally efficacious as disulfiram because of the psychological expectation of harm if one drinks. Acamprosate seems to increase the probability of abstinence in patients who are recently detoxed, but not necessarily of relapse to heavy drinking. Naltrexone seems to be most effective to reduce relapse to heavy drinking, and acamprosate plus naltrexone has no added benefit. As I noted, for additional compounds, the search for new pharmacologic interventions continues as we understand more about the neurobiology of alcohol use disorder. Thanks for your attention.